My name is Dr. Catherine Doval in the Division of Infectious Diseases at UCLA, for those of you who don't know me, and welcome to the second Global Health and Social Medicine Grand Rounds here at UCLA. Today, I'm very pleased to introduce to you Dr. Sarah Hawkes, who is our guest speaker today. Dr. Hawkes is a medical doctor with a degree in sociology and a PhD in epidemiology. She's a professor of global public health at the University College of London and is the director for the Center of Gender and Global Health, as well as the co-director and co-founder of Global Health 50/50, which advocates for action and accountability for gender equality in global health. If you haven't looked it up, I really highly suggest doing so. Global Health 50/50 is very informative, really interesting and powerful. Dr. Hawkes' work spans the spaces of research and policy by working alongside national governments, UN agencies, civil organizations to promote gender and equity in health policies and programs. Today, we're lucky enough to have Dr. Hawkes share with us findings on how sex and gender influence both health outcomes, as well as the career progression of people working in global health sectors. And she'll provide specific examples from COVID-19 outcomes and who exactly is running the COVID-19 response. And we want to acknowledge that while there's clearly a full spectrum of gender identities, each with unique challenges to health outcomes as well as career progressions, this work presented today focuses on the overarching categories of male and female populations in order to allow for comparisons across societies and across countries globally. Importantly, today we'll not only hear about evidence in inequality and global health, but also how we as public health and medical professionals use this evidence in our decision-making moving forward. As Dr. Hawkes is speaking, please feel free to post any of your comments or thoughts, questions in the chat box throughout the talk, and we'll be able to bring them up for conversation at the end of the talk. Thank you so much. And without further ado, Dr. Hawkes, please feel free to continue.
Thank you very much, Kate. And first of all, thank you so much for inviting me to talk with you this morning, your time. I'm sitting in Cambridge in the UK, so this afternoon, my time. And it's a real pleasure and an honor to be speaking at UCLA. I've been working in the field of global health for close to 30 years now, and I have to say that for a substantial proportion of the time that I've worked in global health, when I introduce myself, people usually assume that when I say UCL, that I really mean UCLA. So I can only conclude after 30 years that your marketing department is far more successful than the marketing department at UCL, because far more people in global health have heard of UCLA than UCL. So let me just situate UCL with the second largest university in the UK. But I think kind of most importantly for the purposes of this talk, we're actually the third oldest university in England, and the first university to admit women on an equal basis with men. So UCL was established about close on 200 years ago with the express purpose of admitting people into academic study who were not men and were not Christian. So as you can tell, you know, I come from an organization that had a fairly radical history. We still like to think of ourselves as needling the establishment and the status quo in the work that we do. And hopefully what I'm about to present to you in the next 35 minutes or so will give you some idea of how we're trying to needle in the 21st century, but continuing to grapple with some of the same problems that essentially existed even 200 years ago, i.e. systems and structures that were set up by and to serve very narrow sections of the population. And you might conclude by the end of this talk that, okay, we've made some progress over the past 200 years, but not nearly enough as we could and should have done. So I'm just presenting this slide to sort of give you an idea of where I situate myself and where I come from academically. So I'm an academic with training in various disciplines that can be applied to public health, as Kate said, and for 20 odd years have worked on the intersection between gender and health outcomes, but also have worked on the intersection between gender and career outcomes. And it's both of those lenses and both of those fields of inquiry that I'll talk about in the next half hour. And I'm putting these papers up just to show you that, I guess, like many of you on this call, I had spent a large amount of my career being part of the academic publishing industry, where we're all measured by money in and papers out. And I'm still very much part of that industry. But when it came to questions of gender equality in both careers and health outcomes, it became increasingly clear to me that no matter how many publications I had in what are considered to be high impact journals in our field, I wasn't seeing enough action, there wasn't enough change happening on the basis of empirical evidence. Now, I've spent the past 15 years studying the relationship between empirical evidence and policy processes. That's probably a different talk, but those studies and that discomfort with the lack of action being paid, or attention and action being paid to questions of gender in the health and medical fields was really the catalyst for thinking about how to communicate this knowledge and these ideas in a different way. And that's what really led us to establish Global Health 50/50 about 3.5 years ago. Was really a concern that what we needed to do was to communicate differently, to advocate in a different way, and to get different groups of people involved, who really were all, lots of people all on the same side, but perhaps working in different silos, and really think a lot more creatively about how we should communicate. And so we set up Global Health 50/50 about, as I say, about 3.5 years ago, in order to not just advocate for gender equality within the global health system, but very specifically to hold the global health system to account for the commitments and the promises it had already made over many, many years for notions of gender equality and health equity. And so we established GH 50/50 as an accountability mechanism. And one of the key principles of accountability arising from the human rights literature is that it needs to be based on independent monitoring of whatever it is that you're concerned about. And so for us, we have established a system of independent monitoring of how the global health system is performing with respect to gender equality. And we are concerned with gender equality as it applies to careers and career advancement, but also gender equality as it applies to the policies and programs that influence health outcomes. So as GH 50/50, and when I say we, in an incredibly gender equal way, I mean both me and my husband. So this is a joint partnership. My husband is a political economist of global health and was head of political affairs for a UN health agency. And so together we established GH 50/50 in order to really, as I said, just have a different way of thinking about and articulating the problems that exist within the global health sphere. So we produce annual reports. We have an index of 200 organizations within global health, and we look at how they perform across these two related domains of careers and health. And then we produce guides based on best practice, and we do a lot of public engagement. For example, through an annual photo competition that explores public understanding, the public discourse around gender. You know, when you hear the word gender, what does it mean to you? How would you portray it? How would you capture it? How do you visualize it? So our photography competition, which has just opened up, by the way, for the photographers in the audience, please have a look at our website, because there is a cash prize. But this is really just an illustrative way of really trying to get across the a very different set of messages about gender. You know, thinking, I won't spend too long talking about the photography competition, but you know, one of the really strong pushes that we were trying to make as in opening up a competition called This is Gender, What Does It Mean to You, was to move away from the very staid representation of gender that has been so frequently part of the global health framing of what gender means to most organizations in the global health sector, i.e. it's about women, it's about girls, and it's about vulnerability and disempowerment. So we really wanted to challenge that and say, well, what does it mean to everybody else? And that, I think, leads me into just a couple of a brief overview of what it is that we're trying to do, not just in Global Health 50/50, but also in all of the academic work that we do alongside the empirical and the theoretical work that we do around gender. Is we're constantly looking for evidence of the relationship between gender equality and health equity. And then particularly for Global Health 50/50, we're really trying to capture how do organizations respond to that evidence. And importantly, who is it who's making decisions about how that evidence is responded to? So I'm just going to start, you know, like every academic, I'm sure, who comes onto your video screens, everybody has their own conceptual framework of what it is that they're talking about. So here's our conceptual framework. And one of the things, and Kate has put this very beautifully, and that in the following slides, I'm going to talk about male, female. And I mean, I can explain to you now why I'm talking about male, female, and I'm certainly happy to answer questions on it. But I'm talking about male, female in relation to COVID, because that's the way the data is collected. You know, we've all got our own ideas about what gender means. We all have our own philosophical and hopefully progressive definitions about gender as a spectrum, and gender, what gender means in relation to biological sex, and gender as a social construction that is expressed through gender identity that changes over the life course, may be at odds with biological sex, etc., etc., etc. And we totally capture all of that in most of the academic work that we do. But the reality of what we're able to capture as an accountability mechanism, as an organization that looks at other people's data outputs, in the case of COVID, looks at the data outputs from national governments, is that we're essentially stuck with the male-female binary. That's just the way the data is put out into the public domain. So when we think about gender in our conceptual framework, by gender, I really, you know, it's a shorthand way of talking about absolutely everybody in society. We're not focused on one part of the gender spectrum over and above any other part of the gender spectrum. But what we do say is that gender is a social construction, that as a social construction, it intersects with other determinants of health inequity, like ethnicity or class or caste or geographical location or disability. So gender almost never acts entirely by itself to influence health equity. It's about the intersecting often vulnerabilities or inequalities that drive health outcomes, that gender is enacted through a series of health behaviors, whether those are protective health behaviors, such as people accessing care when they feel unwell, or accessing screening services because they want to protect their own health, but also importantly, the gendered nature of health behaviors that really involve exposure to unhealthy environments or products. So in other words, the gendered nature of who drinks alcohol or who smokes tobacco. And I'm going to come back to that a little bit later. But also, and I think really fundamentally, because at the end of the day, we are sociologists and political economists as well, we're very interested in capturing how gender is embedded within institutional structures and organizational structures, and what that means in terms of certainly what that means in terms of equity. And we think that gender it interacts across these three spheres to influence outcomes of both gender equality and health equity. So that's, that's what we think about gender, but we're also acutely aware that gender is a very political construct. It's a very political, highly politicized topic. I mean, it always seems to me that if you're talking about something that is socially constructed, there really shouldn't be too much argument over whether or not it's a social construction or a biological fact. Or an inherited biological domain. But as you know, we live in a highly political world, as every world is, as every period of time is highly political. And one of the things that divides politics at both global and national levels in many countries is around the not just the laws or the construction of gender, but the actual definition of what gender means. And, I've put up a few examples here. I'm sure you'd be able to populate these with even more examples to say that, whilst we in global health and across much of the health and development sector take it as fairly evenly read that gender is a social construction, that a lot of the world actually doesn't agree with us. And when they hear the word gender, what they seem to be hearing is the word homosexuality. I mean, you can see that happening with Bolsonaro in Brazil, for example, or closer to home for you, it becomes really clear that when certain American politicians hear the word gender, they seem to be only able to focus on the transgender part of the gender spectrum, and kind of and enact laws and rules purely in relation to that. So given that, you see from our public engagement that beautiful set of visual representations of the glory of the spectrum of gender and the highly political notion of gender within many governments or many political spheres, how do we move forward from that? Well, one of the great things within global health is that there is, after all, a normative agency. There is an agency that tells us, as people working in health and medicine, well, if you want to think about gender, here's a definition for you. And since we are the normative agency, wouldn't it be great if you could all use this definition? So this is the definition. I mean, we can critique this definition, but here's a standard way of thinking about what gender is, how to undertake, for example, discourse analysis about gender coming from the World Health Organization. So this definition for us in Global Health 50/50 forms the basis of how we then look at all those 200 organizations in the global health ecosystem and look at how they talk about and think about gender. So why bother to do this? Well, partly we're doing it because it's been known for a very, very long time that if you look at sex disaggregated health outcomes, and I'm going to revert back here to talking about sex differences because this is the way the data is usually presented in these kinds of documents. It's male, female, it's binary, and it's sex disaggregated rather than talking about gender disaggregated. So sex disaggregated differences in health outcomes have been well known for many, many years. But when every year, the World Health Organization puts out World Health Statistics, which is the sort of the snapshot of what illnesses are most prevalent in the world in different regions and different countries. And for the very first time in 2019, it actually sex disaggregated the data. And here that is the data on life expectancy. And even for those of you that aren't epidemiologists on this call, you'll be able to see if you simply look at that graph and all of the circles, the blocked in circles are women, and all of the empty circles are men, and the different colors represent the income levels of countries in the world by World Bank classifications of income levels. And you'll be able to see immediately that irrespective of the income status of the country, that women live longer than men. And the global average for that is about 5 years. It ranges between about a year in some countries up to 11, 12 years in other countries. And we can have a chat about that later. But here's what WHO then identified as the key reasons why we see those differences in life expectancy. There's not a single country in the world where women don't have a longer life expectancy than men. And here's the main reason why. It's predominantly the non-communicable diseases. And I've highlighted a few because they're going to be important as I move into the next part of the story. But you can see here that there's on the right hand side of this graph where you've got some yellow bars. What you've got is conditions that contribute to women's lesser life expectancy. These are the conditions that mean women die prematurely: breast cancer, cervical cancer, and Alzheimer's. But everything on the left-hand side is the conditions that contribute predominantly to men's lower life expectancy. And I've included this slide just to remind you, as I kept on saying a few minutes ago, this is not anything new. Here in the UK, we've had the empirical evidence of that gap in life expectancy and the lower life expectancy of men, the higher rates of infant mortality in young boys, for example, ever since the work of the founding great grandfather of epidemiology and demography, John Graunt, who looked at parish registers in the 1650s, early 1660s in London and a rural area, and started to map out the fact that men die at younger ages. Men don't live as long as women live. And he put it down to men dying by reason of their vices, which is a narrative that will be familiar to anybody who has looked at masculinity theory and looked at or indeed many people who haven't looked at masculinity theory, but have looked at a newspaper and have seen all of the discourse around toxic masculinity. This idea that you've got men doing bad things to themselves has been around since at least the 1660s as the explanation as to why men don't live as long as women. So what's any of this got to do with COVID? Well, I'm giving you this as a background, partly to explain to you what it is that we do as Global Health 50/50 and why we're now focusing on COVID, but also to really try to sort of point out to you from the beginning that the story I'm about to tell around COVID is not a new story. COVID is not an exception. COVID, in fact, fits a bill that, as you've seen, is a bill that we've known about for many hundreds of years. So within Global Health 50/50, every year we collect data on on whether or not those 200 organizations sex disaggregate their programmatic data. So if an organization is responsible for delivering 20 million vaccines to children in South America, for example, are they delivering 20 million vaccines to boys or girls or both, and what's the proportion? And what we find again and again at each year that we've measured it is that a minority of organizations think about sex disaggregating their data. So in the vast majority of cases, we have no idea whether the delivery of these policies and programs is benefiting men or women or boys or girls, because the organizations themselves do not present their data in sex disaggregated way. So when COVID came along, we were really, really interested to see how the world was going to think about sex, gender, and COVID. Were there, there was suddenly an explosion of epidemiological data, as I'm sure you're all aware of. You've got that fantastic Worldometer tracker and the Hopkins tracker, and so many data sites that you can go to capture information about COVID, and so many country sites that you can capture information about COVID. But what we were interested in right from February onwards was, well, how many of them are going to think about sex and gender? And we started looking in early March, and we were disappointed but not surprised to see that only a minority of countries that were reporting COVID cases were actually doing so in a sex disaggregated way. So we thought, well, okay, if it's not at country level, it must be at the level of WHO, because they're the people in charge of actually pulling all of this data together. So we looked at the WHO data, and lo and behold, it wasn't sex disaggregated. And we kept on looking, and we wrote to WHO and said, where's your sex disaggregated data? And it turned out that although they can recommend sex disaggregation to countries, they can't insist on it. And so there was no global repository for sex disaggregated data. So we thought, somewhat naively looking back, well, okay, we will do that then. And now we're tracking 179 countries at vast amounts of person hours to actually go through huge amounts of government websites around the world to actually find the data for every country that's reporting COVID cases over, I think it's about 1,000, although we've got some exceptions to that. When you've got more than 1,000 COVID cases, we try to find out, are you reporting those cases in a sex disaggregated way? And then what are you reporting about all of your other data points? And what this slide really shows you is that the majority of the world is still not thinking about COVID in relation to sex and gender. So what you see on this map is that any country in red is a country that hasn't reported any sex disaggregated data point in the past month. The yellow countries are the ones that have reported either cases or deaths, and the greens have reported cases and deaths, sex disaggregated, in the last month. But overall, over time, what we've seen is this bar along the bottom, that remarkably few countries tell us anything about who's going and getting tested. So we've got a fair amount of case data that we can look at globally, but we've no idea whether we're seeing disparities in cases because we've got disparities in testing rates. And, for those of you that are at all interested in the epidemiology of COVID, you might think that the very first question you'd ask to explain differences in case rates is, well, is it because we're seeing an underrepresentation of certain groups in the population who go and get tested? Anyway, I mean, I hope that line along the bottom is pretty self-explanatory. And what this now does is shows you what we have found in terms of sex disaggregated data across all of the countries where we've got data from. What are the differences that we see? Well, in fact, we do see a difference in testing data. And that difference in testing data is in the favor of women being more likely to seek testing than men. And that absolutely fits with all of the literature from various systematic reviews that show that in terms of screening services, women seek out screening services more than men do. When it comes to cases, you've got a very slight male excess in cases. When it comes to hospitalizations and ICU admissions, you've got a very noticeable male excess. And then you've got a male excess when it comes to deaths as well. So if, when we've got the sex disaggregated data there, we are then able to look at whether or not we see differences, and then begin to explore the question of why do we see the differences? Well, even though I've spent a lifetime working in the field of gender, I would never sit here and say it's all about gender. I am absolutely 100% of the opinion that sex and gender are totally interacting together to influence the kinds of outcomes that you're seeing here. This is not all down to gender differences, and it's very unlikely to be all down to sex differences either, because if it was all down to sex differences, we would expect to see these figures be relatively constant in most parts of the world, and they're absolutely not. They vary quite a lot, which I'll show you in a minute. And those really, really amazing researchers, particularly, the lab-based researchers who do work on sex differences, looking at biological differences between people with XX chromosomes and people with XY chromosomes, are able to see that, there are clear immunological and hormonal differences between people with those chromosomal makeups that may explain why we're seeing a higher susceptibility to severe infection and death amongst people with XY chromosomes. But I'm a gender researcher, so I can't go into too much detail about the sex differences. Instead, I'm going to talk to you about the gender differences. And here's the slide that says to you that I think this is why gender matters. Because if we look at aggregate measures at the national level of gender equality, actually gender inequality in this case, it kind of doesn't matter. The graph would just go the other way around, but this is gender inequality at the national level. So I'm not entirely sure why Slovenia and Yemen are highlighted here, but let's give you the example of Slovenia and Yemen. So Slovenia is a country where you've got relatively high levels of gender equality. That's probably the best way of thinking about it. Men and women are relatively equal in Slovenian society. I'm sure there's lots of inequalities there, but in terms of what the UN Development Programme measures for gender equality, Slovenia is not doing too badly. Whereas Yemen, on the other side of the graph, is doing quite badly when it comes to gender equality. So there's women in Yemen are definitely more unequal than men in Yemen. How does that then relate to the proportion of COVID deaths? Well, what we see here is a statistically significant relationship between aggregate national measures of gender equality or inequality and the risk of men's death. The more gender unequal your society, the more likely it is that men are going to die from COVID. Why? Well, I think I'm going to go back to my conceptual framework here, and just emphasize again that some of that is probably down to biological risk, but I don't think I don't think that can explain this graph in full. So if we think about gender as being an explanation, we know that some of the difference might be around risk exposure. So we've got data on female health workers, and we see that female health workers get more exposed at higher rates of cases than male health workers, and that but that doesn't necessarily then lead to higher rates of death amongst female health workers. The same for cases amongst migrant labour workers in the Gulf and in the countries of Southeast Asia. We see vast excesses of men diagnosed with COVID in those settings compared to women. But again, this is fairly young men, so we're not seeing such high rates of difference as far as death is concerned. But where we think that some of the differences some of the explanatory variables for why we see those differences might lie in two areas. One is gender being embedded in institutional structures. So if you think back to that graph and you think about Yemen and the other parts of that quadrant of the graph are some of the countries of South Asia, for example, countries with very high rates of gender inequality. Is it because, are we not seeing women being admitted to hospital and women dying because women with COVID? Is it simply because women actually don't get into hospitals? When you've got hospitals where, in order to be admitted to ICU, your family has to pay a huge amount of out-of-pocket expenditure to get you into the ICU, is a family less likely to do that for the female members of the family compared to the male members of the family? We know that that's the case in other conditions. Is that what is happening in COVID? Does that explain some of the differences? Is it that women's deaths actually just don't get registered at the same rate that men's deaths get registered? We know that at least 60% of deaths globally never reach vital registration systems. Is there a gender bias in whose death actually gets registered in the system? All of that could be an explanation as to why we see those differences in case rates and in hospitalization rates and death rates. But it's also the case that when it comes down to that smaller quadrant, or that smaller part of the figure here, gender is enacted. The work that we've been doing for many years suggests that this may also be playing a role in why men have a higher risk of severe COVID infection and risk of death. And I'd like to present the next slide to you. Let me see. Yep, here we go. What this slide really, really simply says is that men have higher rates of risk behaviors. It leads them into higher rates of NCDs. We know from lots of studies that are currently underway or have been published over the past 8 months that there is a very strong interaction between having NCDs present and risk of COVID, of severe COVID infection and severe disease and death. So is it around men and their NCD risks is that part of the explanatory pathway? So I just want to remind you of, I'm going to show you some work that we did 2 years ago to explain, to really remind you why we consider risk behaviors in relation to NCDs to be a very gendered phenomenon. This is data that we pulled together from the WHO annual smoking surveys. And so the acronyms at the bottom are the WHO global regional offices. So you've got the Southeast Asia region, the Western Pacific, the Middle Eastern region, African region, European region, and the region of the Americas. And what we've got here is men in blue and women in yellow And it's smokers divided into young people under the age of 24 and people aged 25 to 69. And again, you do not have to be an epidemiologist to look at this bar chart and realize that smoking generally is an absolutely male behavior. You know, globally, 86% of smokers, adult smokers, are men, and 83% of younger smokers are men. That almost by definition fits the picture that this is a masculinized behavior.
Dr.
Yeah.
Hi, sorry to interrupt. There's a question on the chat. Would you mind, from your, I think, 2 slides ago, restating one more slide? Being able to restate how many deaths are not being reported on a global scale. I think you were discussing on the slide that that may be an issue.
Absolutely. So there's a couple of Lancet papers on exactly this. In fact, I think it was a series of papers came out about 4 years ago on vital registration systems. And at that point, it was about 60% of deaths are not being registered in vital registration systems. And importantly, neither are about, I think at that point, it was about 25% of births. It may have improved in the past few years, but it probably hasn't improved to the extent whereby one could discount the notion that there is still a huge number of unregistered deaths and births, and that there may be gender inequality embedded within that lack of registration.
Wonderful, thank you.
No problem. I'm almost at the end, so you can ask lots of questions in a minute. So, you're all health professionals. You're not going to be at all surprised when I put up my next slide and say there is a problem between smoking and having a risk of NCDs. And if we go back to that first slide or first set of slides that I showed you coming from WHO, if you look at the top differences in what explains the differences in life expectancy between men and women, a large number of those are associated with smoking rates. Reviews published a couple of years ago, about 5 years ago, looking at 120 years of mortality data in 15 industrialized countries, attributed 30% of the difference in mortality rates, premature mortality rates, i.e. Lower life expectancy of men compared to women in those 15 countries, 30% was directly attributable to tobacco smoking. So, our theory is that one of the reasons that we're seeing some of these higher rates, higher excess rates of COVID, severe COVID disease and risk of death in men compared to women is because of these underlying NCDs. And of course, the NCDs have a biological factor as well, but they are driven by very gendered behaviors across every society where that we've looked at. So, here's kind of the sort of what can we all do about it slide. Well, one of the things that we could all do as health professionals is to think about sex and gender in all of the work that we do, whether what we're doing is bench level work or clinical work or public health work or a mixture of all three. But when we looked, this is another piece of work that we're doing with GH5050, when we looked at the first 1,000 COVID papers that were published, you can see here that there is remarkably little evidence that the health research community actually takes sex and gender into account. There's lots of work in this area to show that as health professionals, we routinely overlook the importance of sex and gender in all of the work that we do, and COVID is no exception to that. And I have to say that I've actually come across papers as part of this systematic review. I've come across papers that are clinical reports. We looked at 50 cases of people with COVID. Here's what we found. And they don't tell you, even if it's men or women, let alone do they tell you, and, five were people with non-binary identities. There is none of that information in a very large number of papers. So that's the kind of overview of how the health system and health professionals think about sex and gender, i.e. that a very large part of the time they don't think about sex and gender at all. In contrast, and this is actually most of the work that we do as academics, in contrast, the people selling the products that are predominantly being bought by men up till now have been acutely aware of the importance of gender norms and the manipulation and exploitation of gender norms in order to sell their unhealthy products since at least the 1930s. And there's the sophistication with which they have used gender to sell unhealthy products knows almost no bounds. And whilst it might be under regulatory control in industrialized countries right now, it's also really clear that the big tobacco and alcohol companies, for example, have entire departments set up to now sell their products to women in Asia and Africa. So I'm just putting this up there to say that whilst we as health people might ignore sex and gender most of the time, the rest of society is actually using sex or using gender in very manipulative ways. So it's the last, I realize I've gone over my time, but just the very last couple of slides to say why, why have we been so blind to sex and gender in health and medical systems? And sorry, I seem to be missing a bit of background on that slide, but one of the things we've done with GH 5050 is look at who runs global health. And we think it's no coincidence to find that the vast majority, over 70% of the leadership of global health is male, including the senior management. And when we look in a more intersectional way at that leadership, what we find is that it's 70% male, 80% from high-income countries, and 90% educated in those high-income countries. So in other words, what you've got is this incredibly narrow slice of humanity that tends not to be interested in sex and gender, despite the fact that actually men have these worse health outcomes. Bizarrely, men in leadership completely overlook all of that. If they do think about sex and gender, they tend to only think about it and deliver organizational policies and programs that address gender in the incredibly narrow domain of women and reproduction. So there's a huge amount of work in these 200 organizations on women and reproduction, very little work that would count as these leaders promoting and delivering programs that are gender responsive across the health field and for the entire population. And we think that that's because the leadership of these organizations is so narrowly drawn. I mean, you can see there's some figures in here that for example, only 5% of the global health leadership is women from low and middle income countries. So I think that, I've got a summary slide here, and I always think summary slides are actually, they never really capture everything you want to say. So I'll leave this up because I think I've probably said more than enough. I realize I've gone way over time. So I'm gonna stop here and perhaps leave that up for a second and stop sharing and be ready to answer your questions. Thank you.
Great. Thank you so much, Dr. Hawks. That was very informative and helpful, particularly having the framing and understanding why maybe this lack of gender and gendered data, segregated data. We do have several minutes for some questions and answers. Let me give you two questions from the audience. And if we have time for additional questions, we can go from there. The first is from Kevin Blair. The question is, in our own research, if we want to strive for wider adoption of gender disaggregated data, what is the best way to separate it? So what is kind of the gold standard? We could clearly have a dichotomous categories, male, female, but having more categories that include trans male, trans female seems optimal. So what is your suggestion as we're exploring our own disaggregation of data within research?
That's a really good question. And if we were all designing data collection systems and data presentation systems from scratch, I think that at a minimum we would want to know what's your sex, what essentially what sex were you born, what's your gender identity now, and I think from that, if you had sex and gender, you would be able to capture most combinations, including those people who identify as non-binary or those people who identify as trans. I have not, and I'd love it if somebody was able to fill in my knowledge gaps here. I haven't come across a national surveillance system that presents data in that way. But if anybody does know of data being presented in that way, please let me know, because we would love to investigate that further. But I think if you captured that, sex and gender, we would be moving forward.
Thank you. And I think the piece that you talk about where the existing literature on COVID is largely not disaggregated. This is 2020 data being published. I wonder if you have any suggestions of how we as researchers and in the medical profession can encourage our fields to start disaggregating data more, and if there's a particular message that seems to resonate with people.
Yeah, it's a really interesting question, because some of the other work we've been doing in GH 5050 has been a very systematized review pre-COVID of how sex and gender is captured. This was in 12 journals in both the general medical field and the global health field. And what we've seen is very, very similar to that one graph I showed you with the bars. So those bars relate to a set of guidelines about how to present sex and gender in your research. And those guidelines are called the SAGER, SAGER. I could put it in the chat. The SAGER guidelines, and they are they're the kind of gold standard for how we should all be thinking about and presenting our research. And those guidelines are supposed to be used by journals and journal editors and peer reviewers when they assess publications. So, in theory, we're not supposed to see the kind of picture I showed you on that bar chart, because there is this set of guidelines that says this is how to take sex and gender into account, and everybody should be doing it. But we've had lots of discussions with journal editors who essentially say by the time they receive a paper, that's the end of the line. They can't now persuade people to do sex and gender analysis when people haven't collected the data, for example. So I don't know how it works in the US, but in the UK, one of the things that we've been pushing for is that this should be part of standard funding. That if you're applying for funding for your research, as part of the general application for funding, you should be able to say what it is that you're doing about how you're going to analyze through a sex and gender lens in your research, because you essentially you can't wait until the point of publication to start doing it. So we think it's inherent in the funders to push for it, but also for the kinds of academic communities that we all exist in, where we help each other by peer reviewing each other's work before we submit a funding application, or peer reviewing our work before we submit a paper, etc., that, you know, there are opportunities there to persuade each other that it's really important to do this. But again, you know, I'd be really, really grateful for ideas from all of you as you know, how do we get people to pay attention to this?
Yeah, wonderful. Thank you. In our last minute, there's one more question, but I'm not sure that we'll quite have time. In our last minute, I want to make sure to bring your attention to the QR that's on your screen. We'd really appreciate any feedback that you have. If you wouldn't mind filling out this brief, I believe it's a 7-question survey that will certainly be helpful for Dr. Hawks and for us with the Ground Round series that we're starting. And I believe, Rachel, do we have a slide for just to give information about the next presenter or the next speaker? And here you can see our next Ground Round speaker for November. Dr. Hawks, thank you so much for your time. This was very informative, gave a lot of food for thought. And I encourage all of us to be thinking about how we can incorporate gender into our own work and encourage it within others, the work around us.
Pleasure. Thank you.
Thank you, everyone.